All right, so moving on to lecture 20, we're still going to be talking about compatibility, but a little bit more specific. Just when you guys are performing your cross matches or doing unit compatibility testing, make sure you follow your institution's SOP, all right? So if your institution has the capability to do electronic cross matches, make sure that is included in your operating procedure. If your procedure doesn't have electronic cross matches, you will have to perform initial spin on every unit. Every patient cross match that you perform has to be initial spin, all right? Label and release blood. We've talked about the requirements for labeling the units and the requirements for your patient sample. Patient identification is very important in blood bank. So I always encourage students to double and triple check yourself. Just get in the habit of double checking everything. And again, that label on the blood unit needs to match your patient exactly. All right. So if your medical record number is one number off, maybe there was an inaccurate keystroke in the entry, then you have to investigate that. You have to figure out what's the correct medical record number. Is my sample in this unit going to is it the same patient? All right. So we do a lot of investigations in blood bank. All right. And whatever testing you perform, your initials or your ID number is always attached to that testing. So if you did ABO, RH, and an IAT and set up 2 units on a patient yesterday, I can log in the system and see where, Fiona set up these 2 units yesterday, all right? The computer will tell you. So it's always attached. We can always see who did what. I mean, we've talked about this before, but this is actually the back side of your unit. So if you guys remember the front side of the unit, it has your unit number embedded in this barcode. And so on the back of the unit, you have all of these stickers. And so these can peel off. So if you are cross-matching the unit or you're confirming your ABO RH upon receipt, you can peel these stickers off and put it on your tube. It reduces the amount of labeling you're doing by hand. Right, so you can do that. And then also, this is your patient identification. This is your transfusion sticker that has all of your patient information on there. They put it on the back side to notate that this unit is going to this patient, right? And then once this unit gets to the nursing floor, the nursing staff must verify this information as well. Okay? All right, so issuing blood to the nursing staff. It's an elaborate system, all right? So remember, before that unit leaves blood bank, not only has the testing tech verified their work, but the issuing tech will also confirm patient ABO and RH, confirm compatibility of the unit, confirm all attributes have been needed or been met, like if it's antigen negative, if the patient needs irradiation, if the patient needs leukodepleted or washed product. The issuing tech must make sure that all of those attributes are met. Does anybody know what the #1 error in blood bank is? Clerical error, all right? So that's why we have these double check systems in place, is to reduce the amount of clerical errors, all right? And so just to give you an idea of how this works, I've seen it done 2 different ways. If your system has if your hospital has a tube system, which most larger facilities will have a tube system that goes to everywhere on campus, right? They use it as their transport system, delivery system. What's gonna happen in blood bank, once the testing is performed, the units are ready for transfusion, when the nursing staff is ready to transfuse the patient, they will send down what we call a blood request or a transfusion slip. It will have the patient information, it will have the product requested. That lets the blood bank know that nursing staff has the patient prepped and is ready to start that transfusion within 30 minutes, right? They have 30 minutes to get that transfusion started. All right, so we receive that. We will pull that unit that has been cross-matched on that patient. We will issue it in our computer. We do our clerical check. Remember, 2 blood bank technologists must verify it before it's sent out. And then we put it in the tube system and send it up to the floor for transfusion. All right, so if you have a tube system, you can deliver units that way. If you don't have a tube system, then a physical courier must come down, bring the transfusion slip, hand delivered to blood bank. We will issue it in the computer, and then that courier takes it back up to the designated floor. All right. So that's the nursing staff has to let blood bank know that they're ready for transfusion. Okay. We don't just cross match these units and then send them up. We don't know, and maybe that patient's not in their room at that time. Right. So nursing staff has to let us know that they're ready because of that 30-minute time requirement. All right. Once that unit gets to the floor, the nursing staff will then again verify patient identification, either with their hospital ID band or if they've used that Type X armband that we talked about, that special blood bank armband. And then again, 2 nurses will again sign the form verifying that they have identified the patient. So your patient identification matches the unit identification, all right? And this just lets you, this kind of outlines the flow of the transfusion process. So the nursing staff is going to confirm the identity. That's actually during the phlebotomy process, all right? So then you're gonna collect the sample. Blood bank is gonna receive that sample. They're gonna perform their transfusion testing. Again, making sure the sample matches the requisition. Again, verifying patient identification. Oh. Sorry. Right, and then compatibility testing is going to be performed. Donor units are going to be brought into inventory at the hospital, all right? So they have units that are ready for transfusion. Donor units are selected for the recipient, and then the cross-match is performed. All right, so what happens after that cross-match is performed, a standard order is usually for 2 units. Most people order a type and screen and 2 units cross-matched. And so then the testing technology sets up those 2 units, cross-matches, they're tagged for that specific patient. They're put into a special refrigerator in blood bank where all of the cross-match blood goes. So those units are no longer in your inventory. Well, they're there, but they're in a different status. They're in cross-match status. Okay, so they're assigned to a patient. And then when the nursing staff is ready, the processing staff will pull that unit and go through the issuing process. Okay, send it up to the floor. All right, so what are some causes of incompatible cross matches? Maybe due to a typing problem. All right, so we've talked about a ABO discrepancy, subgroups of A. If you have an A2 patient with anti-A1 and you cross match an A1 patient on them, what do you think that, how do you think that interferes with your cross match? Your patient has anti-A1 and you're giving them an A1 unit. So that's gonna cause agglutination in your test tube. So you're probably gonna see a 3+, 4+ reaction at initial spin. All right, because remember A1 is a initial spin reacting antibody, one of our ABO antibodies, okay? So that could cause a incompatibility. All right, so if you have a subgroup. Any type of rouleau, because remember, in the major cross-match, we're using patient plasma. So patients with multiple myeloma, anytime they have excess protein in their plasma, it can cause the cells to rouleau. Rouleau can cause false positives, okay? That would cause an incompatibility. So I want you guys to think about when it's incompatible, that means patient's antibody is reacting with your donor cells. That is a positive reaction. Positive reaction is incompatible. That means in vivo, your patient's antibody is going to attack those donor cells, okay? Allo antibodies. So if your patient has a allo antibody and you give them antigen positive blood, that will cause a incompatible cross-match, all right? Same with auto antibodies. If your patient has an auto antibody, whether that unit is antigen negative or not, that auto antibody is going to react. That is why for patients with auto antibodies, we usually give them least incompatible. And then technical problems, it could be technologist error. Maybe you added the wrong patient plasma to your cross match, okay, whether that causes an ABO discrepancy or maybe you let's see, Maybe you add in an additional reagent to your cross matches, all right? That would cause incompatibility. We talked about the weak subgroups. So if you have a patient with A2 and they have an anti-A1, what's the best unit to transfuse them with? So Katie says O. Could you give them an O? Yes, and that is what BloodBank is going to do, all right? We are not going to type all of our A's to find out which of those A's are A2, right? Right, that's very time consuming, and only about 1 to 8% of the population is A2, right? So more than likely, you might not even have any A2s in your inventory, right? So we would just give them type O, right? Now, if you have a unit and you know it's A2, that patient can safely receive that A2 unit, but you have to type that unit for A2, and that A2 would have to be logged into your inventory. This unit is A2, safe for transfusion for my patient that is A2 with anti-A1. Does that make sense to everybody? Right? All right, so acquired antigens, we talked about the acquired B, all right? So looking at patient history is very important as well. Patient history is very important too for females that have had previous pregnancies, all right? That's one of the ways that patients build allo antibodies, okay? And if they've had previous transfusions. That's the other way that they can build unexpected allo antibodies. Non-specific agglutination. This would be like everything is agglutinating, very similar to a warm auto antibody. What you can do is if you think your patient cells might be coated with extra protein, something that's reacting, then you could wash those patient cells. All right, and that should alleviate all of those agglutinations. And newborns, remember, have we talked about Wharton's jelly yet? We'll talk about that definitely when we get to the newborn, but Wharton's jelly, if you receive a cord blood, there is Wharton's jelly. It's kind of like a support substance of the cord blood. It's very gelatinous. It can cause false agglutination if you don't wash appropriately. So if you're ever doing cord blood testing, it's very important that you wash a minimum of 4 to 6 times, okay, before you do your cord blood testing. Mixed cell populations. So if you had a patient that is one type and has been transfused with another type, that could cause 2 cell populations. You have patient cells, and then you also have donor cells, all right? That could give you a mixed field agglutination. Also, if you have a bone marrow transplant patient that has received an allo transplant from a different ABO donor. Katie, did you have a question?
Yes. So on Wharton's jelly, you said wash 4 to 6 times. But what would we be, I guess, since they don't develop antibodies in the first 6 months, would we just have agglutination for ABO typing?
Yeah, it will. I can't think of a reason that you would use cord blood for cross-matching, no. And definitely if you have pan-reactivity, meaning everything is reactive with your plasma, you do not want to wash your plasma, right? Because it will not, you just wash it away, right? And then always keep in mind diseases that weaken your A or B antigens, all right? Such as those patients that are on chemotherapy, those patients that are older and their ABO antibodies are not being expressed, that would be another reason. And so just to review, you guys know rouleau due to the excess protein. If you ever suspect that you have rouleau, you can actually look under the microscope. You will see formation. You'll see the stack of coins. All right, you can verify that under the microscope. So in your cross matching, just like if you were trying to resolve your back type, you could perform your saline replacement. All right. So if you do have an alloantibody, very important that you honor that alloantibody. Okay, do your workup, identify that antibody, give antigen negative blood. If you give antigen positive blood, it will cause your cross match to be incompatible. Okay. And then also if your donor, we talked about this, if your donor has a positive DAT, that will cause a incompatible cross match at AHG phase of testing, all right? If your patient has a cold autoantibody, such as big I, little I, H, or the compound IH, that could also cause incompatibility. Typically, you'll see that incompatibility at initial spin. If your patient has one of these autoantibodies where it's incompatible at initial spin, but then if you perform it at 37 in AHG, you warm it up so that agglutination is going to dissipate. That's the time that blood bank will recommend the use of a blood warmer. All right. And then a warm autoantibody. So some technical problems, and these are the same that we've talked about before that can cause false positives, so false agglutination. If you have any type of debris or trash in your glassware, that can be mistaken for agglutination. Bacterial contamination might cause clumping, and you might mistake that for agglutination. Fibrin, especially if you're performing cross matches on a sample that has been in the refrigerator, maybe for, remember, because we keep our samples for 3 days. So it is not uncommon for additional units to be added on. So you have to pull your sample and perform cross matches. So it's not uncommon for fibrin to form in that plasma after being stored at refrigeration for a period of time. So a really good rule of thumb is if you're cross matching on an already refrigerated sample, centrifuge it down, right? Make sure that fibrin is at the top of your red cells. Okay, so then you just have fibrin-free plasma. It's a really good practice when you're pulling a sample out of the refrigerator. Contamination of saline, all right? So if you think about when you're filling up a tube and think about your saline bottle, how it has that spout on it, a really good practice is not to put that spout into your tube because then you have contaminated your saline bottle. So it's a really good rule to hold it above your tube, right? So like if you're washing your red cells or anything like that, don't let that spout touch the contents of your tube, okay? Centrifugation, if you over centrifuge, okay, that could cause the cells to be firmly packed and then you might not shake hard enough to get your true negative result. And then red cell suspension, all right? Special circumstances in compatibility testing. So these are special donations. One is autologous. All right, so think about what autologous donation means. That means that I have pre-donated a unit of blood that is, I am the only designated recipient. It's my blood. Maybe I'm scheduled for surgery 3 weeks out, and then I don't want to be exposed to a random donor. I would rather receive my own blood. So that unit is only specifically for me. There are some lesser restrictions on infectious disease testing, so it can never be entered back into your regular inventory. It can go to nobody else, all right? If they decide I don't need it, that unit is actually wasted, all right? So it could potentially be a very expensive donation if it's not used. Katie, did you have another question? No. Autologous, I need to tell you guys this. Autologous is the safest type of transfusion. Receiving your own blood is the safest, all right? Number one, because it prevents you from being exposed to foreign antigens, so you're not going to be allo-immunized. You're not exposed to the potential for other infectious disease, right? Because it's your own blood. If you have an infectious disease, receiving your blood will not affect that, right? And then intrauterine transfusions, we talked a little bit about this in a previous lecture. Remember that that blood must be fresh, all right? So it must be CPD, anticoagulant, and it must be within 5 to 7 days old. It must be O negative, it must be leukodepleted, and it must be irradiated. And I say leukodepleted or CMV negative, okay?
What would happen if you had like a warm autoantibody and you try to do an autologous donation for yourself for like a surgery? Would you be able to?
I think you would be able to, yes. And again, that would be probably the safest route. Yeah. Now, if you were to do, because sometimes with autologous units, and you'll have to follow your facility's SOP, and depending on if it's a autologous unit, they might not even perform cross-matching. They might have, you know, because it's going to be labeled with that patient identification on it, and it's only designated for that patient. So they might just automatically set it up on that patient. So depending on what your facility's testing requirements are. But the autologous would be the safest for that patient with the warm auto. And depending, so sometimes patients with warm auto, think about it, they might have that warm auto might be causing them hemolytic anemia. So then in that case, they probably will not be eligible to donate, even though for autologous donations, remember the requirement, the hematocrit requirement to donate is about 38%, right? For autologous units, that hematocrit requirement drops to 33%. So if you have a patient that has warm auto hemolytic anemia and their hematocrit does not reach that 33%, they might not be eligible to donate. That would be the problem. It's very important that you guys understand that some type of cross-match needs to be performed before that unit is issued, all right? Whether it be an electronic, initial span only, or initial span 37 and AHG. So some examples of incompatible units. Let's say you have a positive IAT, all right? But your auto control is negative, so you're not dealing with an auto antibody, you're dealing with an allo antibody, but your major cross-match, your cross-match pops up positive. What are some reasons for that? What does the positive IAT tell you? There's an unexpected allo antibody there, and if your cross-match is incompatible, what's the most probable reason? That unit is probably antigen positive for whatever antibody is in your patient plasma. Okay, that will cause an incompatible cross-match. All right, so here's your example. If you had a negative IAT, your auto control is negative, but your major cross-match pops up positive. What are two possibilities there? So your patient has an antibody to a private antigen that is not included in the IAT, but your donor unit is positive for it, okay? Or your donor unit could have a positive DAT, okay? Yeah, and always remember too, if it pops up that 4+ at initial spin, reconfirm your ABO compatibility, all right? Make sure your unit type is compatible with your patient.
So would that include like A2 with anti-A1?
Yeah. Here's an example, positive IAT, where your auto control is positive, and then your cross match is also positive. What do you guys think about that? What does that positive auto tell us? They have an autoantibody. Remember, autoantibodies react with everything. So that's why your IAT is positive, your autocontrol is positive. Every cell that you test in your panel is going to be positive. The DAT is going to be positive. The eluate is going to be positive. Your cross matches will be positive, right? This is the problem for patients with warm autos. Everything is positive. It's very difficult to identify any underlying alloantibodies, okay? Could also be Rouleau, remember, because anything, the excess protein in the patient plasma causes the Rouleau. So anything that uses patient plasma in your testing could have false agglutination, all right? All right, so just some reviews of typing problems. What do you guys think about this one? You're not given A1 lectin results. All right, so probably what's happening here, why would your anti-A be negative? So Aaron said, oh, what would your A2 cell reaction be if your patient was type O? It would be positive, all right? So that lets us know that we're not dealing with maybe a weak subgroup or a weak back type, okay? So something, remember, if you have a subgroup of A that weakens the A antigenic expression, so it's very common if you have a subgroup of A to have a negative reaction here, all right? So this is probably a subgroup of A. Does that make sense to everybody?
What would our A1 look?
You tell me. So if you have a subgroup of A, if it's a subgroup of A, that means they are not A1, right? And so if you are testing non-A1 cells with A1 lectin, do you have agglutination? No. So your A1 lectin would be negative.
So on the test, you give us the A1 lectin result?
Yeah, you would have A1 lectin. A good rule of thumb, anytime A1 lectin and A2 cells run together, and why A1 lectin wasn't included here, I'm not sure. But if you perform A2 cells, you also run A1 lectin. They are always performed together. They might have included A2 cells just to let you know that it wasn't a type O patient with a weak back type right here. So here's another one. You have, let's see, Sarah. So Sarah says that AX confuses her. So AX is just a notation meaning that that patient is a subgroup of A. So they're not A1, and you remember there's tons of subgroups of A. There's A2, there's A3, there's EL, there's tons of different types of subgroup. In this class, we have specifically concentrated on A2 because it is the most common subgroup of A, but there are plenty of other subgroups of A. So when your patient is a subgroup of A and you don't know exactly what subgroup they are, it is denoted AX. Does that make sense? So it's not really, X is a subgroup of A, it's just meaning it's a subgroup of A and we don't exactly know what it is. All right, does that make sense to everybody? You would have to definitely do molecular testing to differentiate exactly what type of subgroup it is. Okay. Does that help, Sarah? Yeah. All right, so the next example, notice that you have, your patient looks like an AB in your front type, but looks like an O in your back type. A2 cells were not performed, but you have a negative IAT. What do you guys think about that? Would you suspect Rouleau? Why? But your IAT is negative. All right? So if you have Rouleau, not only would you have this in your back type, but your IAT would be positive as well. So it's not Rouleau. So what you have to think about is negative IAT, so it's not an autoantibody, not something in my patient plasma. So these results are probably correct, right? So it's not affecting my patient plasma, it's in your front type, all right? So what could cause a pan-reactivity in your front type? You guys remember we talked about polyagglutination? All right, so if you were to test A, B as well, your D and your D control, they're probably all going to be positive. What is something that we could do? Probably your patient cells are coated with something that's reacting with our reagent. Not an elution. First, you would remember, because typically if a DAT is interfering, we will only see that at the AHG phase of testing, all right? This is polyagglutination. You could wash your patient cells. That should remove whatever is coating patient cells and will dissipate these reactions, okay? Do you think this would affect your cross-match, polyagglutination? Why do you guys say yeah? Your IAT is negative. Remember, your cross-matches use patient plasma. So whatever's coating patient red cells will not affect your cross-match, because your cross-match is donor red cells mixed with patient plasma, okay? So here's another one, 4+ reaction with anti-B, positive reaction, or sorry, 4+ with anti-A, a positive reaction with anti-B, negative with A1 cells, positive reaction with your B cells, and then a negative IAT.
Is that required?
Yeah, that's what that is. And remember, acquired B from that bacterial enzyme, it's usually a gram-negative bacilli that removes the sialic acid from the cell membrane. Or sorry, no, it changes the oligosaccharide to make it look like the D-galactose. How would you transfuse this patient? You could give them A, but you could also just give them O, just to be safe. All right, so here's another one. What's your front type look like? B, but what's your back type look like? AB. Our A2 cells are negative, and then our IAT is also negative. So what do you guys think is causing the discrepancy in the back type? Let's see.
Would babies even have a positive front type?
Babies will have a positive front type, yeah, because they have the antigens, they just haven't built the antibodies yet. So this could be an older patient who has weakened antibodies, all right? So that's why you don't have a reaction with your A cells and your A2 cells, right? Because if this is a B patient, they should react with A2 cells, all right?
Is it immunocompromised?
Yes, so older patients immunocompromised. So it could be a baby too, because babies are in that immunocompromised population. All right, so here's some cross-match problems. What would you expect if your major cross-match was negative, and your IAT is positive, your DAT is positive? What explains that negative major cross-match? What must you do if you have a positive IAT and you identify an antibody? Honor it by giving what?
Negative.
Antigen negative units. So this is what we want to see in blood bank. If your IAT is positive and you identify the antibody and you give antigen negative units, then your major cross match should be negative, right? So this is described as antigen negative cross match compatible. Okay. What if your IAT is negative, but your minor cross match is positive? And remember, minor cross match is donor plasma mixed with patient red cells. What do you think is causing that? The positive DAT. All right, so remember, it's different from a positive DAT in your donor. This is a positive DAT in your patient. All right, so positive DAT in your patient, you're adding patient cells mixed with donor plasma will give you an incompatible minor cross match. And remember, minor cross matches are not performed in blood bank anymore, so you probably will never see this. Okay. Why does that positive DAT not affect your major cross match? What's in your major cross match? Patient plasma mixed with donor red cells. All right, so remember the DAT is on your patient red cells. Okay, so it will not affect the major cross match if your patient has a positive DAT. Okay. What if you have a negative IAT, your patient has a negative DAT, and your major cross match pops up positive? What if I told you your major cross match was positive at AHG phase of testing? Donor DAT. Your donor has a positive DAT. So do you see how you have to approach these? You have to ask yourself what is being tested here. All right. In the major cross match, you have your donor red cells mixed with patient plasma. Right. If your donor has a positive DAT, your major cross match could be positive at AHG. Okay. If your patient has a positive DAT, then that would affect your minor cross match. There's another scenario for this third example here. Does anybody know what it is? If your IAT is negative and then your cross match pops up positive, actually two. What if your patient has an antibody to a private antigen? Okay, that would happen here. What if the unit you decided to cross-match in the major was the wrong ABO? All right, that would happen in this scenario as well. Okay. There's some information that you're not given in this scenario. So if your donor unit has a positive DAT, you will only see that at the AHG phase of your cross match. Okay, does that make sense to everybody? If it's wrong ABO, you will see that at initial spin. Like you're going to see it immediately. It's going to be very obvious to you. And then if your patient has a rare antibody, typically, depending on what type of antibody, if it's a room temp reacting, you could see it at initial spin. Otherwise, if it's a AHG antibody, you would only see it if you did the AHG phase of testing. Okay. Does that make sense to everybody? All right, so now we get into our beloved frequency calculations. So how many units do you need to antigen type or cross-match in order to find a compatible unit for your patient? Now this gets, the number gets higher the rarer your antigen is, okay? So keep in mind, if your patient has an antibody, we have to give antigen negative blood. So what's the frequency of that antigen negative in your population, all right? So with D, if your patient has anti-D, you have to give them D negative blood, only 15% of the population is D negative, right? So how many units do we need to cross-match in order to find D negative? For D negative, obviously, it's not that many because we test every unit for the D. But if you were doing little e, right, only 2% of the population is little e negative, okay? So here's an example. You need to cross-match 2 units on a patient with 3 antibodies, okay? So the rarity of the antibody plays a role and the number of antibodies, okay? So the more antibodies the patient has, the harder it is to find compatible blood for them. So your patient has anti-D, anti-Kel, and Duffy A. How many units do you need to cross-match? All right. So your antibody chart that is in lecture 9 gives you the frequency of these antigens, okay? Keep in mind, the frequency of those antigens is the population that is antigen positive, all right? So if you are looking for donors that are compatible, you will need to subtract that number from 100 to get the population that is antigen negative. Okay, does that make sense? And here's your chart. All right, so an example of that, your chart says 85% of the population is D positive, so that means 15% of the population is D negative. So when we're looking for compatible units for a patient that has anti-D, we are only able to look at 15% of the population, okay? 9% of the donors are Kel positive, so then we actually have 91% of the population that's Kel negative, all right? 66% are Duffy A positive, so then only 34% of the population would be compatible for a patient that has anti-Duffy A. Right? So everybody see how that makes sense? Right? When you have an antibody, we're looking at the population that is antigen negative for that corresponding antigen to that antibody, right? So this is really just all math. You're just going to multiply the percentages of the frequency of these antigen negative. Okay, so in our patient who has D, Kel, and Duffy, we need a D negative unit, we need a Kel negative unit, and we need a Duffy A negative unit. So 15% of the population is D negative, 91% of the population is Kel negative, and 34% of the population is 34. So you just multiply those frequencies together and you get 0.046, or 4.6% of the population would be antigen negative for these 30 antibodies. Okay. All right, so now that you know what percent of your population is negative, you can figure out how many units you need to cross-match. And so you just divide the number of units by the percentage, right? And so if we need 2 units divided by the percentage, then you get 43 units that will need to be cross-matched. All right, that's a lot. All right, so if you're working in blood bank, are you going to cross-match 43 units? No, so depending on the size of your facility, you might already have some antigen-tested units on your shelf that you can pull from, or you are going to call the reference laboratory and say, I need a Rh negative, Kel negative, Duffy A negative unit. Okay. So one of your assignments for this module is a bunch of frequency calculations, determining how many units to cross-match, and or what, if you're given a specific population set, what is the frequency of the population that would match that person's phenotype. Okay. Now you could also add in ABO. All right. So this is not taking into consideration your ABO. All right. This is just antigen negative. All right. So if your patient is A negative, then you could also put in, I think it's 46% of the population is type A. You could also put that frequency in as well. All right. For the exam, you will have some frequency calculations. You do not need to memorize the percentages. I will tell you. All right. I will tell you that 34% of the population is Duffy A negative. However, it might be written different. it might be written that 66% of the population has the Duffy A antigen. Okay, so you need to be aware of that wording. All right, so 66% of the population have the antigen, only 34% of the population would be compatible. All right, so you guys need to be able to understand that frequency. Okay, so if 66% have the antigen, 34% are going to be antigen negative. Okay. And then it gets more complex too. If usually you have to look at the wording of the calculation. So it will tell you to consider ABO. It will tell you to consider ethnicity. So if you're looking at the white population, the percent of antigen frequency, or the black population. So it can get very specific. All right, so just make sure you pay attention to the wording of your question. If it doesn't mention ABO at all, if it just says what percent of the population, don't worry about ABO. Don't figure it in your calculation. But if it says what percent of the A population would be compatible and antigen negative for this patient, then you need to consider your ABO in it. All right, so your instructions will be very specific. Oh, it was 40% of the white population is type A. On the exam, I don't want you guys to worry about memorizing these frequencies. I will tell you. I will tell you that 45% of the population is group O, 40 is group A. I will give you those frequencies, okay? I would rather you spend time on other stuff, all right? So here's an example. What percent of the white population are O positive and have the KEL antigen? All right, so we're looking at the O positive population that have the KEL antigen, all right? So, and it's the white population, yeah. 45% of the white population are O, 85% of the population, does it say the D? Yeah, D positive, 85% are D positive, and then 91% of the population are KEL negative. So 9% of the population is KEL positive. So this is how you can consider in your ABO. Does that make sense? So about 3.5% of the white population, O positive, KEL positive. Little side note, I am B positive, KEL positive. So I am in that 9% of the population that's KEL positive. I know. I think that was the only really weird thing about my phenotype. Yeah, that's a good idea. And then here's the question, what percent of type specific could donate for a patient with the KEL antibody? So in order, this is a question that says type specific. So in your question, if it said what percent of the population could donate to an O patient, then you would have to include the O frequency, okay? All right, so in this lecture, we talked about some reasons for incompatible cross matches. Remember, typing problems, so if you have a subgroup of A, that could cause an incompatible cross match. Rouleau, allo antibodies. So if you have an allo antibody and your unit is not antigen negative, that would cause a incompatible cross match. Autoantibodies, we have established that they will have incompatible cross matches, and then some technical issues as well. And then frequency calculation. So as you guys are doing that activity, let me know if you guys have any questions, all right? Does anybody have any questions right now?